Thank you, everybody, for joining us for the ultrasound lecture series today, or Ultrasound Grand Rounds today. We are wrapping up, this semester here. We have today and next week, and we'll be taking a little bit of a break for the holidays. But I certainly am excited about today. I think we have some pretty exciting things to talk about today and even next week. So I'm hoping that you guys, enjoy today and come back for next week. But today we're going to talk about a case, talk about ultrasound, how we can use ultrasound to assess, patients' physiology, better understand what's going on, provide a little bit more nuance than what we may be used to in the emergency department, but certainly something that would be necessary in the critical care environment. And so I think you're going to find it interesting, find it fun. I have invited with me a guest speaker or a guest. You all know Dr. Shaman from the ICU, who is a good friend, a good mentor, and a fellow sonophile. And so we're going to basically go through this case and we're going to talk about it together. And hopefully we'll all learn something. So with that being said, let's switch over to the slide set here. The first thing, as we kind of get into this, is basically we're going to talk about this case, right? I have intentionally obscured the data, right, just to protect the patient's privacy. Normally in our conversations, we talk generally about a topic, right? And then we'll have representative images kind of with that topic. But since today we're talking about a specific case, I wanted to further obscure that just to protect the patient's identity, given the HIPAA considerations that are involved. So specific details have been changed, but it shouldn't affect the conversation today and the nature of the case. And so with that being said, let's assume for the sake of this conversation that we are in the emergency department and we see a 68-year-old gentleman who presents saying, I've been feeling a little bit winded lately. And I'm a little bit more fatigued, and maybe the patient's not saying it, maybe their family's saying it. But dyspnea and fatigue is going to be the complaint here. And, we can look at their vitals. The blood pressure is, 110/80, not bad, and for the sake of today, we'll just assume that the patient's not normally like super hypertensive. And so this isn't a concerning pressure for us right now. Heart rate's fine, a little tachypnic, right? 22, satting 95% on a 2-liter nasal cannula oxygen requirement there. We can just say that maybe that's new. Maybe it was in the low 90s when they first rolled in. And now they have a 2-liter oxygen requirement. So you kind of get this picture. This is something that we see routinely in the emergency department, certainly not uncommon presentation, even from the ED up to the critical care environment. And we can start picturing in our head patients that we've seen like this, right? And so I'm going to just tell you, I don't have the information here, but I'm just going to tell you that the EKG shows maybe some chronic changes, but nothing acutely ischemic, right? We're not going to the cath lab. This isn't coronary disease, active coronary disease. The chest x-ray shows some pulmonary congestion, right? Some pulmonary edema and some vascular congestion. And the biomarkers are positive, right? There's a mild trope elevation, certainly not high, but a little bit elevated. And the BNP is going to be elevated, definitely above a baseline that we would consider to be normal, right? So that's the general picture that we're getting. And with that, we did a basic ultrasound, right? And so here's our basic windows. We have the parasternal long axis view and the parasternal short axis view. We can say from this, we can kind of glean, we'll kind of go through the basic windows quickly because I want to get to some other stuff. But from this, we can basically glean that there's no effusion, right? That's a good place to start. The ejection fraction looks grossly normal, right? Maybe we can nuance that a bit, but you can see that there's a decent squeeze in the LV. And you can look at the the RV LV here, and maybe the RV is just a touch big on the parasternal short, but there's certainly bowing of the septum into the RV, or kind of that donut sign that would suggest that the RV pressure isn't super duper high. So no smoking guns really in either of these images, right? And then we can go down to the subcostal window here. So we have the subcostal or the subxiphoid 4-chamber view. And we see kind of roughly the same thing. And looking at the IVC view, we can see a very plethoric IVC. So I don't measure it here, but it's going to be 2 centimeters or more. And there's really no collapse with any form of respiratory effort, right? So we can say it's a decently high RAP or right atrial pressure for this patient, right? And that's really kind of where the big finding is, at least right now in the basic ED ultrasound. And then finally, we'll round it out with the apical 4-chamber view. And we kind of get more of the same, just from different perspectives. And so with that, Z, do you have any comments or any things that you want to mention here before we get too far into this?
Yeah, I like the images, and I like the fact that you recorded all of them, because it's often that we go back to look at the images after the fact and try to compare all of the views. I agree in this view. Things might be a little foreshortened. It makes the atria look big, or they might be big. I'm definitely interested to see where we're going to go with the case, because the patient did have what looks like a little bit of dyspnea, and I'm interested to evaluate the lungs based on heart images.
All right, so let's go back to this case here. So basically, kind of adding a few other things. And Z, feel free to just chime in if you have any comments here. And I got some questions that we'll throw out in this case, as well as we go through this. But just to add a little bit of extra detail to this case, we have our tricuspid view and our mitral view, and we can see that there's a moderate to severe degree of tricuspid regurg. It's a little bit hard to see, but you can definitely see it kind of hits the sidewall, wraps around to the back wall. So that really is getting into my category of that moderate to severe TR. And then the MR, we definitely see a very sizable plume that kind of gets almost to the back wall. So I don't know if I'd go all the way to say severe, but it's certainly, moderate, MR in this patient. So I don't know, Z, does this do anything for you? Does this add anything that, to what we already know?
Oh, yeah, definitely. I mean, you get the patient who's got lower extremity edema, you look at the IVC, and the IVC is big, and then you translate this to pulmonary edema, but in reality, the right side is a reflection of what's going on in the lung, not the cause of what's going on in the lung. So evaluating the left side is probably more important right to start with, and then you go to the right side.
Sure.
But I wanted to ask, I mean, we don't see it here, but if we had a McConnell's sign, how would you use that when the free wall of the RV is dysfunctional? The apex is hyperdynamic, and it's kind of pushing in. And in that case, the TAPC is going to be reduced. Do you put a lot of weight into it? Because I know the numbers aren't that great for the sensitivity and specificity of McConnell's sign.
Personally, I don't put a ton of weight into it. I know what the numbers are, that it's decently specific for PE when you see it, but I think that notion has been a little bit it's fallen a little bit out of favor over the years, and it's a factor, right? It would suggest an elevated, right-sided pressure from a PE, but it certainly is not exclusively associated with. I don't know. Do you have a different understanding than that?
Yeah, that's the same. If there is a McConnell's sign in someone who's hypotensive or in shock, there is more weight you can put into it. But if it's there and the patient is not hypotensive, then only about 30% of people with PE will present with a McConnell's sign when they're not hypotensive. Only 30%. So it's not that great if the person clinically looks stable. If clinically is deteriorating and in shock or near arrest, and you see McConnell's sign, then you can put more weight into it.
Yeah, and I think that, goes along with what we'd see in the ED. Like, I don't think anyone's going to diagnose a PE exclusively on the presence of a McConnell's sign. Though if you have a crashing patient and you see a large RV and a McConnell sign in a previously normally healthy heart, I think it begs the question. You have to explain it then in that context.
Hey, it's Prerna.
Yeah.
Matt, I jumped on a couple minutes late, but first of all, I'm really glad we're doing this topic. But I have a question for you. As far as the plethoric IVC goes, do you have a number that you use? Do you only use the greater than 2.1 that we see in data? Because there's so many papers with varying weight on whether a plethoric IVC and what numbers to use. Can you share a little bit about what variation percentage you would use and what absolute diameter you would use?
Sure. So what I roughly use, the literature I've seen basically breaks the IVC into three categories: RAP of 5, RAP of 10, and RAP of 15. And so the one that I remember is 2 centimeters and no variability with respiratory effort gives you an RAP of 15. If you are that 2 centimeters with some variability with effort or with respiratory effort, it's going to be around that 10 range. And if you're less than 2 centimeters with lots of variability with respiratory effort, it's going to be in that 5 range. The exact numbers I'd have to go look up on a table, but that's roughly what I use. Z, do you have anything different?
Yeah, I looked up the numbers before we started.
Good.
So it's
Thank you.
yeah, sure. It's less than 9.9 or less for the lower range. If there is variability of more than 50% with a sniff, or which the American Society of Echocardiography also mention is you can use 20% variability with tidal breathing, which we never really look into because we say sniff, and then the higher
non-intubated patient.
Yes, for non-intubated patients. Yeah,
Okay.
or if the person is intubated and you can afford to put them on a spontaneous breathing trial without PEEP, then they can behave as if they're not non-intubated. And the higher end 2.1, and again 50% or 20. But there is a problem with the right atrial pressure estimate from the IVC. I think there was an agreement of only in 35% of the time between invasive measurement and non-invasive measurement for the whole range. In the higher end and the lower end, there was a little bit more agreement. In the middle range, there was pretty poor agreement.
Yeah, so it's a good estimator test. It's not a really good to get a specific number, but it will come into play here in a little bit. Okay, let's keep moving here for a little bit because I have some interesting things I want to get to. The other part of the valvular assessment that we looked at is basically their aortic valve. And so here's a short axis view of the aortic valve. And I wasn't able to get really any good Doppler views through it to get a Doppler waveform. But essentially what we see here is a really, really tight aortic stenosis. So this would be kind of that severe to critical aortic stenosis level of tightness. And again, there's parameters that you can put on that to measure it in terms of your Doppler velocity through the valve. You can do your valve size, things like that, and figure that value out. But I'm just going to tell you it was severe AS. And here's just a representative, clip of that severe AS. So that's kind of the initial study, right? So we had the images, kind of a little bit of that valvular assessment. What I'd like to do for the rest of the time is just kind of dig deeper into the various different components to really understand the cardiopulmonary physiology that's happening. And with that, hopefully we can then get a better understanding of what to do in the ED and the critical care environment. And I was going to mention it earlier on, but I'll say it here. One of the things that happens in the ED, the typical management of the undifferentiated dyspneic patient that we get the feeling is probably pulmonary edema, probably some degree of cardiopulmonary dysfunction, we'll say that, is say, well, they got pulmonary edema, they must be fluid overloaded, so let's give them diuretics. And then if the really savvy ED consumer or ED provider says, well, part of heart failure is also afterload reduction, so maybe we should reduce some afterload too, right? And so while that may be a good initial strategy as we're differentiating that, the question then comes up, and Z and I were talking about this beforehand, is number one, is that the best strategy? But number two is, what if something goes sideways, the patient becomes hypotensive or something like that, and then we need to intervene upon that, right? Whether it be a complication of our management or just progression of the normal physiology that we're experiencing, what do we need to do? So with that in mind, like those questions in mind, we're going to kind of pursue the rest of this this conversation and some of the images that we have, right? So as we kind of break these different components of the heart function down, I think the big obvious elephant in the room is the LV function, right? And as we mentioned before, we can see we have a decently normal global squeeze. We just look at it and just the function appears grossly normal, right? Now it's helpful, right? Especially if you have a trained eye. But if you need a little bit of extra, quantification to help you out in that one, here's an example of using the EPSS technique, where we're measuring the mitral valve leaflet tip, and it gets really close to that septum. It's within 5 millimeters, which would be considered within the normal parameters. And so that would suggest this patient's LV function is normal, at least from an EF standpoint. And I didn't put the formula in here, but you can type it into a formula and get an actual number that it operates decently close to the actual, EF. The other way of doing LV function is looking at your cardiac output, or at least a surrogate for your cardiac output, using the LVOT VTI, so left ventricular outflow tract, velocity time integral, which is part of the calculation when you want to do a cardiac output assessment. You certainly have to add in, this gives you a cross-sectional area of the flow through the valve, so you need to add in the volume component and then multiply that by the heart rate, to get your complete cardiac output. But a normal VTI is going to be greater than 20 centimeters here, and this one is about 18, so it's maybe slightly reduced, from normal, but not far off. So I don't know, Z, did you want to kind of weigh in any thoughts about the VTI? I know we talked about it a little bit earlier, but the VTI versus ejection fraction assessment.
Oh, definitely. I mean, you get a patient who is hypoperfused. Maybe this person wasn't hypoperfused yet, but eventually they will probably become. So you get a person who's hypoperfused, you look at the heart, and then you see poor ejection fraction, or you see, let's start with good ejection fraction. And then now you want to know, is this ejection fraction really going through the LVOT? And is this ejection fraction pushing enough volume of blood? I would say go for the VTI and measure it. It's very hard to overestimate the VTI. You can underestimate it. So if you get a number that's more than 20 in someone who has a mitral valve area, not valve, but LVOT area that is normal, and with a heart rate that's 70 to 100, then you have a good cardiac output. You can decide on the perfusion problem is really not a cardiac output issue. There's a local problem, for example. Let's go after the belly. Let's look at other reasons for hypoperfusion. What I'm trying to say is that just because you have a normal ejection fraction in someone who's hypoperfused, you shouldn't stop there. You should look and see, is there forward flow with this ejection fraction? Or maybe the person has a severe mitral regurg and the flow is not going forward, it's going back into the left atrium. But if you have someone who's hypoperfused and you look at the heart and it's failed, you might stop there. It's not perfect all the time, but that would be a reassuring situation to tell you this is the cause of the hypoperfusion, the poor ejection fraction.
Yeah, and maybe another example, just to kind of further solidify it. And this is kind of an unrealistic scenario because there's a lot of other competing medical interests in this situation. But for our trauma colleagues, right? We're very accustomed to seeing patients who are hypoperfused and hyperdynamic, right? Think about the GSW to the belly that's bleeding into the belly, or open long bone injury that's bleeding onto the street, things like that. In that scenario, you would see a normal to hyperdynamic ejection fraction because the heart's trying to work overtime to get as much blood pumped to perfuse organs, but there's maybe just not enough cardiac output because it's just completely insufficiently filled because the preload's just in the toilet. So that may be another example. Again, when I'm not going to do an LVOT VTI in the trauma bay for a GSW, that one's kind of self-evident. But there's maybe another example of where you'd have discordance between the two different values of LV function. Am I thinking right there, Z?
Correct. Yeah, exactly.
Matt, that was a good example. Even, extrapolating it to the surgical ICU, where a lot of the problems we see are volume issues that translate to, looking at the heart, and we typically see a hyperdynamic EF that's just got terrible preload, whether it is insanely amounts of insensible losses or immediately post-op and poorly resuscitated. So thank you for bringing that, etiology up, since that's probably what we see most frequently as surgery.
Yeah. And I know, like, one of the things I remember from when I was training is there's the clinical, like, ICD-10 code. It was ICD-9 then, but ICD-10 code may be the same, right? The example I can remember is pneumonia, right? And the way it gets treated in the surgical versus the medical side might be slightly different based on the different preceding conditions or the physiologic conditions that the patient may find themselves in. Being a patient that's open, right? That's going to change your hemodynamics. or a, whatever surgical indication versus a medical patient who may have, a different set of, pre-existing milieu. So anyway, I thought that was interesting. Moving on to RV function, we're going to kind of slip over to RV quick and then come back to the LV. But as we're just kind of thinking about global forward function, right? So we went from how do the views look and global or like major valvulopathy, now LV function, RV function. In this particular case, we can see that, the RV LV, it's really two things that we look at: RV LV ratio, and then the the TAPSI. I guess in the ED, there's a lot of other ways of measuring it, but RV LV ratio here, I mean, it might be a little bit foreshortened on the LV. My memory of it wasn't ginormously huge. This one makes it look a little bit big, but I certainly would say there's probably some evidence of increased RV size, right? So maybe some chronic, RV strain in this patient. And then if we do the TAPSI view, that M mode through the tricuspid annular plane, it generally looks reduced. It's certainly not as dynamic as I'm used to seeing. When you measure it out, it actually measured at 1.7 centimeters or 17 millimeters, which technically is low end of normal, right? I think in my head, 16, 17, 18 is kind of that cutoff from, abnormal to normal. Like, when you get in the 20s, you're certainly good. When you get below 16, that most of the literature is going to say you're reduced. So maybe you have a slightly reduced RV function on this patient. Z, do you have any comments on this one before we move on to other things?
Oh yeah. So yeah, definitely RV function in the ICU when the patient ends up with us is an indication, and we watch for changes in RV function because it's going to be a quick assessment of what's happening to the pulmonary artery pressure. And I guess we're going to go over some measurements, right?
Yep.
I think.
Yeah. And if time allows, I know we talked about this before. I'm going to throw a curveball in here relative to the RV function. So we'll put a pin in that and come back. Look forward to it. It's called a teaser for the rest of you guys. So let's pop back over to the LV or the left side. So, systolic function is one component to a patient's ability to pump the heart. And I think if you think about it big picture, right, the main point of the heart, and I guess we can spark and create arguments among cardiologists, the RV cardiologist and the LV cardiologist, but the main function of the heart is to pump blood, right? The main function of the heart pumping blood is to pump it to the body, right? Now, the RV folks would say, no, the main function of the heart is to pump blood through the lungs to get back to the heart. But it does the same thing, it pumps, right? So you can have a pump fail, whether, for a number of reasons. One of the reasons is it just doesn't pump, right? You just don't get, flow out of it. And that's kind of what we talked about with the LV function, systolic function. The other reason for it to fail is just the mechanics of it just don't work as smoothly as it needs to, right? And in our situation, where we have a very, I guess, binary functioning heart, right? In that it's like an in, out, squeeze, relax type of a function. It's probably a better vocabulary word for that. But when you have that type of a function, the stiffness of the relaxation phase will affect its ability to fill, right? And if it can't fill very efficiently, it certainly can't pump forward very efficiently. Like if you fill a little bit and then pump all of that out, it's very different than filling a lot and pumping a lot, right? So a very long-winded way of saying diastolic function becomes important when we look at a patient's ability to perfuse and to get blood out of the heart, because it's a function of the patient's ability to fill the heart and get blood in so that it can pump it back out, right? And so in this patient, we measured our mitral valve inflow velocities, which is step number 1 in measuring diastolic dysfunction. And the tall spike there that's measured is the E wave, right? And that is basically the velocity, the peak velocity of the blood flowing through the mitral valve during the normal relaxation phase of diastole, right? And then the smaller peak is the A wave, and that is the blood flowing through the mitral valve as the atrium contracts, right? That extra little kick that the atrium gives. And that's the left side of the screen here. The right side of the screen is a tissue Doppler view, which is basically measuring the excursion of the mitral valve, in this case, lateral annulus, throughout the cardiac cycle. So anything above the baseline, it's going toward the apex, and anything below the baseline is going towards the base. And so the relaxation phase is going to be between the base or below the baseline. The above the baseline is going to be your systole. And so we have that similar E wave, maybe less prominent is, or the E prime wave, less prominent is the A prime wave, as things are relaxing there. And we can certainly put some measurements on that, which is what we did there. And that then can be plugged into, some reference guides. This is one I just Googled and found on the internet. The web address is below. But there's certain patterns that happen as that ventricle stiffens, where the relative heights of the E waves and the A waves change. The relative heights of the E primes will change, and you can basically map out how stiff a patient's ventricle is based on kind of their Doppler parameters here. And so in this patient, we had a really, really high E relative to A, right? That ratio of E to A was like 3 or 4 or something to that effect. It was 180 over 50. And so that's going to put us way far in the far end of the range of severe diastolic dysfunction. And then you could do the E to E prime ratio as well. And ours is going to be, what do we say? Z, it was 20, which is certainly over that 10 that'd be needed to diagnose the severe diastolic dysfunction. So with that, I'm going to go back to this slide. Z, do you have any comments about diastolic dysfunction that you want to add in? Or maybe how does this information then color the patient's presentation with the dyspnea and fatigue that we're now seeing?
So I want to say that diastolic dysfunction kind of scares people a lot because of the E and the E prime and the A and the ratios. And if I want to simplify it, and I want to say, you can do this, I will say you can do it because you're used to looking at the heart from the apical view. So that's the start. It's not a strange view to you. The second thing is that it's not difficult to find the pulse wave Doppler and measure E and A. If you have an E to A that's really high, a ratio that's really high, then you can be sure that there is a left atrial pressure increase, which changes the management from someone who has a pulmonary edema from a viral infection or ARDS or something that shouldn't be diuresed or might not respond well to diuresis, versus someone who is more common and run-of-the-mill heart failure patient who you're looking at a left atrial pressure that's very high, and it makes sense to diurese them. Once you have the ratio between E and A fall into the normal range, then you shouldn't stop there and try to do the E and over E prime. E over E prime requires using tissue Doppler, which is the colorful picture on the on the side, and that with practice, with a couple of sessions, you can definitely do this. Once you do the E over E prime, if the ratio is more than the actual number is 14, that predicts a wedge pressure of more than 20. So that will be the go-to measurement if your E over A, which is the early filling of the LV to the atrial kick, is in the normal range. If the E to A is more than 2, you can stop. You know the left atrial pressure is high. You know this is someone who needs to be diuresed, and you're going to do it. But what would stop you from diuresing everybody is that you might end up like this person who has probably preload dependence because of the aortic stenosis. You're going to drop their preload, and you're going to cause hypoperfusion, especially that their blood pressure is on the margin.
Yeah, and you kind of preempted my next question, and maybe I'll just say it, and you can kind of recap and add nuance to that. But we've been talking a lot about specific ways of measuring things. Here's a new thing to measure. Why do I care? Right? In this patient, why should I take the time to measure diastolic dysfunction in this particular patient?
Yeah, because high atrial pressure confirms that you're doing the right thing, while low atrial pressure or an estimate of the wedge pressure is gonna if it's normal or low, then you're going to diurese someone, and then you'll end up with renal failure and hypotension, and you will have to overreact and give them the fluid back, and it's not going to go in the right compartment anyway. And it's not going to be the right kind of fluid because we have colloids inside our vessels, and you're going to give me crystalloid, so it's going to go straight to the lung. Most of it will go to the lungs. So I think it's very important to know if your pressure, what the wedge pressure or the left atrial pressures are for the patient with pulmonary edema that you want to diurese. So of course, I'm talking like this because I'm a lung doctor and because my patients are either going to end up on CPAP or be intubated if they have high pressure or low pressure pulmonary edema. And in that case, I need to know if I'm going to diurese them, if I'm going to hurt the lungs, hurt the kidneys on the way or not, or am I going to improve cardiac function and perfusion that way?
So let me just throw in kind of a little clinical scenario, just kind of make something up here. We have a patient who's got pulmonary edema, right? Who has, let's say their kidney function is, I don't know, 1.8. We can't make it normal, but we don't want to make it like too severe, right? So they got some kidney dysfunction. Maybe their baseline is 1.2. Got to, so a little bit of bump above baseline. And their pressures are tenuous, right? 90s over 50s or 60s. We'll give them something that gives you a map that's 66, right? And you measure their dyspneic like this. You measure their diastolic function, and it suggests that they got high wedge pressures. You would then say that would be justification to continue diuresing with the thought that we're going to pull some of that extra fluid off, maybe potentially improve their cardiac function, get that pressure up a little bit, and not do terrible harm to the kidneys, versus someone who's got low wedge pressure and you say, you just diurese this off and you're going to make things a whole lot worse. Is that, am I hearing you right?
Yeah, exactly. And there are lots of nuances, of course, in cardiac function. Is there valvular disease? Are there other reasons for the hypotension, like sepsis, and not just cardiac dysfunction? But that's what happened during the pandemic, and might happen again with influenza, is that you get a patient with pulmonary edema, and you need to know if this is high pressure pulmonary edema or low pressure pulmonary edema, because am I going to diurese you, am I going to diurese you and cause a problem, and I have to react and fix it because I have to diurese you, or maybe I don't have to diurese you, and I'm just going to put you on CPAP and crank up the pressure, and that should work as well. So the same scenario. Let's take an influenza patient who comes in with pulmonary edema, and I know that this is usually an older person who might have diastolic dysfunction, and before I hit them with a diuretic, and I already have them on CPAP, am I going to crank the pressure on CPAP and expect them to improve or not? Am I going to hit them with everything and end up with an intubated patient who's on dialysis, or am I going to be kind of careful in just increasing the PEEP and not diuresing them because they turn out not to have high pressure pulmonary edema, only low pressure pulmonary edema? And the distinction between the two is also iffy, but think of it this way: septic patient or a pneumonia patient who has leaky vasculature will have low pressure pulmonary edema, and someone who has cardiac dysfunction is going to present with LV failure, either systolic and diastolic, or just diastolic, and those folks will have high pressure pulmonary edema that, if you diurese them, cardiac function improves, forward flow improves. So you get that elderly gentleman who you have on CPAP of 10, and you gave them Lasix, and their blood pressure drops. Now, did the blood pressure drop because I have them on CPAP, too much CPAP, and they are dry? Or did the blood pressure drop because that's the progression of the disease and I'm not doing anything wrong? So look at the left atrial pressure or an estimate of the wedge pressure, and that will give you an answer. And you might not get an answer. You might do the measurements and be still in the middle zone and not know.
So in which situation then would you just say, we're just going to try, positive pressure, like CPAP, versus, as opposed to diuresis, and see if the patient improves just with CPAP alone or BiPAP?
So in the studies for cardiogenic pulmonary edema, theoretically, patients' outcomes were no different if you used straightforward low flow oxygen or CPAP or BiPAP, as long as you did all of the cardiac management at the same time. Of course, there was a lot of crossover between folks who were on low flow oxygen. A lot of them crossed to CPAP and BiPAP because of intolerance of low flow oxygen. But theoretically, you can start with just oxygen and do the cardiac management with hemodynamic management, and diuretics, after load reduction and diuretics. But if you end up with a patient who has pulmonary edema and you measure their wedge pressure and it's normal or low because they haven't eaten for a couple of days and their kidney function is bad, then I'm just going to put them on CPAP. I'm not going to diurese them at all, or BiPAP, and I'm going to keep cranking up the pressure, and maybe support them with hemodynamics with pressors in that case, if they need it.
All right, well, let's move on a little bit, because I know we have a little bit more to kind of talk about in this realm here in a little bit. In fact, that's coming up here, but this one thing to add, kind of extra, flavor. We measured the left atrial size, and in this patient, it was enlarged. For me, I think kind of 4 centimeters is probably considered about normal, right? When you get past 5 centimeters in this diameter, then we're starting to get into the realm of abnormal. And there's certainly more specific ways of measuring it, but just kind of as a rough number to throw in your head, about 4 to 5 centimeters is kind of your upper limits of normal for LA size. And to me, I interpret this as saying, hey, look, we got some form of dysfunction here. We're looking at severe diastolic dysfunction, which is then causing some volume and pressure back up into the left atrium, right? So just looking at it, I'm going to say your left ventricular end diastolic pressure is probably going to be a little bit on the high side. As we kind of go into some further, quantitative assessment. But anything you wanted to throw on that before I go on to the next slide, Z?
Yeah. So again, going back just to the E over A, if the E over A is more than 2, then you don't need any more proof. That's it. That's good enough.
Sure.
But if your E to A is between 1 and 2, then you need 2 of 3 parameters to confirm that this is a high pressure situation. One of them is the left atrial size. The ASE, the American Society of Echocardiography, use LA volume. I can imagine the diameter is not as good, but it might be good enough. The other measure is the E over E prime. And if that number is more than 14, then you have 2 points for the increased left atrial pressure. And the third item is the TR jet velocity, to tell you that the high pressure in the lung is reflecting on the function of the RV on the right side. But I see that you brought up the wedge pressure equation, so
well, that was a perfect segue to the rest of the measurements that we performed in this patient. So basically, what we did is we measured. We already measured the E and the A waves. We measured the E prime waves. So I plugged that in to get the E over E prime ratio, which gives us a ratio of 20.64 for this patient, or let's just say 20, and then using the formula of 1.25 times your E over E prime ratio plus 2, that equation approximately equals your pulmonary capillary wedge pressure. And I'm saying this authoritatively because you told me this authoritatively last week. And so I'm going to use, source, Ziad Shaman, right? But this is something you taught me, and I thought it was really, really, an interesting formula to then kind of get a number on kind of what we're seeing qualitatively, at least on the 2D echo. So this patient, when you plug it in, right, gives you a pulmonary wedge pressure of about 27 or almost 30, right? And just for reference standard, your pulmonary wedge pressure is going to be normally about 4 to 12 millimeters of mercury. So our rough estimate, based on our echo parameters, shows that this patient has a super duper high, wedge pressure, which is basically a reflection of the left atrial pressures or the afterloading conditions on the lung. Am I saying that right? I know I'm kind of confusing terminology in organ systems, but it's how much pressure does the pulmonary vascular tree see kind of coming from the left ventricle or left side of the heart, right?
Yes, exactly. Yeah.
So to follow that up with kind of what you were saying, that third parameter to diagnose the the diastolic dysfunction is the right side of the heart. So the question that you can kind of think through it, okay, the LV here in this situation is not doing so hot. The lung is seeing a high pressure as it's kind of pushing blood out of the lung back into the heart, right? So we're going to have some degree of congestion. Well, we have congestion there in the lung. We see that. What is it then doing to the right side of the heart? How far back are we kind of affecting in our cardiopulmonary assessment in this patient? So moving back to the right side of the heart, we have two images, right? We have the left side image, which shows the tricuspid regurg velocity. And then we have our IVC view, right? And so the way I'm looking at this, right, is saying, we all have a trivial amount of TR, right? But as we increase the amount of pressure afterload that the RV sees, right, it's going to not be able to pump that forward as well, and it's going to regurgitate back into the RA, right? And so we're going to have an increasing degree of tricuspid regurg in this particular patient, or in these patients, right? And so we're measuring this here, and it measures out at about 53 millimeters of mercury, which if you pop it into the modified Bernoulli equation gives you, and our machine is really convenient, it calculates it for us, about 3.6 meters per second, or 33 centimeters. Oh, I said that backwards. 3.6 meters per second, giving you 53 millimeters of mercury. You want to,
and that's only the transvalvular gradient. That's only the backup on the RV. That's making the blood back up into the right atrium.
So that's your pressure differential between your RV and your RA, essentially is what we're looking at. And so in order to get to what is your pulmonary artery pressure, right, you have to then add in what is our preloading condition of the RA, right? So if you have your RA preloading condition, just think about it backwards, going from the bottom up, right? So how much pressure comes into the heart, right? What's the differential between the RA and the RV, right? Add those two together, and that's the pressure that you're going to see going out of the RV into the lungs, right? Your systolic pulmonary artery pressure, right? So if you want to throw that into a calculator, here's what we get. That modified Bernoulli equation gives you that 53 millimeters of mercury as your transvalvular gradient. Your RAP is, in this situation, like we talked about earlier, estimated about 15 millimeters of mercury based on the fact that it's greater than 2 centimeters and not collapsible. Sum it together, we're looking at a systolic pulmonary artery pressure of almost 70, right? And so the question then becomes, what's our parameters? What's our cutoffs? And is systolic pressure a good surrogate? And from your lecture from before, Z, so go check it out on the YouTube channel for the rest of you guys, MPAP, or mean pulmonary artery pressure, is the better diagnostic tool to measure pulmonary artery hypertension. But certainly when it's severely elevated in this SPAP, it can suggest that. And I don't know, Z, do you want to weigh in a little bit more, kind of nuance that a little bit more? The numbers I have in my head are 25 and 40. Am I correct in that, or is there other numbers that you need to think about?
Yeah, I think these numbers are really good. Of course, if it's 23 or 25, it's not going to make a big difference. But 25 and 40 is really a good ballpark for the numbers. Now there is something here I want to point out, that if you see right-sided failure and you see high pulmonary artery pressure estimate from the right side measurements, it doesn't mean that we started with a case of someone who has diastolic dysfunction and has aortic stenosis and has pulmonary edema that is high pressure. And one of the effects of high pressure pulmonary edema is what's happening on the right side of the heart. If you see right-sided failure, don't try to imagine left-sided failure to be causing it, because you can have pulmonary disease causing this, and it's really not related to there you go, pulmonary hypertension secondary to LV dysfunction. But just before we jump there, I want to say that there are a couple of pitfalls in measuring this that could be serious, and one of them is of course, you can have a sampling error. If the jet of the velocity, if the regurgitant jet going in one direction and you're measuring at an angle that's more than 15 degrees, you can underestimate the jet velocity that way. If the right atrial pressure estimate by looking at the IVC is not accurate, then you're going to add a number that's not correct. Here we added 15 because we have good images. You might not have any TR jet, TR regurgitant jet in someone who has a really tight valve, and it doesn't mean they don't have pulmonary hypertension. So if you don't see a jet, you can't exclude pulmonary hypertension. And then remember the intern who's going to hold the probe backwards, not the intern, maybe the medical student, who's going to hold the probe backward and measure the mitral valve regurgitant jet and try to convince you that this was the tricuspid valve regurgitant jet. And that's going to give you a very high number most of the time. And it's not, of course, indicative of pulmonary hypertension. And of course, the picture that you show with the envelope, it's not always going to be smooth. Sometimes there's going to be some broadening of that signal wave because of turbulent flow and in the sample volume that you set. If you're using a sample volume, in this case, you're using continuous Doppler, which is cleaner. So if you have a kind of a picture that's not so clear, you might end up overestimating or underestimating the jet. So those are kind of the pitfalls for measurement on this side. But if you think somebody's gonna, no one is gonna measure the mitral valve regurgitant jet and convince themselves it's tricuspid. I've seen it happen twice in the past 4 years, so it does happen even with expert hands.
So the next thing I just wanted to mention here, and we'll maybe see this in passing because I want to get to 2 questions at the end here. But just for the sake of everyone who's watching this, pulmonary hypertension, which is essentially what we're measuring here, comes in 5 flavors. Right? There's chocolate, vanilla, strawberry, and no, I'm kidding. There's type 1 through 5. And this essentially, primary pulmonary hypertension, secondary to LV disease, pulmonary hypertension secondary to lung disease, the thromboembolic, category, and then everything else, right? And without getting into the nuances of all that, I think one of the reasons that it's helpful to know this is basically say, look, an isolated view of pulmonary hypertension is helpful, right, to some degree, but you have to put it in the context of the rest of the cardiopulmonary picture to really fully understand what's going on with the patient, what you need to do. You can't just measure it, high five yourself, like, wow, that felt cool, I did something advanced, without fully understanding what the loading conditions on the lung are, because obviously the management, is going to nuance itself out into very different ways, down the line. But with that said, I'm going to flip over here, just kind of a summary picture. All right. This is just going to remind us of where we've been today, where we're going to say we have a patient with severe AS, right, who's got decently, I didn't put an LV function picture in here, but they got a decently normal LV function, but we have some diastolic dysfunction, right? And we have some pulmonary hypertension that we see reflected through through our right side of measurements. And that's kind of the scenario we got. And so I think we have a good understanding as to why the patient's dyspneic, what we're going to do about it. We've talked about that, but I want to throw 2 curveballs here at you, Z, and just kind of see where you want to go with this one. And this is the way I like to think, right? We have a pretty standard thing. Wow, I made it through that one, and I was able to help the patient out. Now, as I'm driving home, what if I change parameter X or Y, right? How would that affect my management, right? So this is all in a spontaneously breathing patient who has a small oxygen requirement, right? They're on 2 liters nasal cannula. There's nothing fancy about that right now. Let's intubate this patient. How does that affect the parameters that we're seeing, right? Physiologically, and what are we going to do potentially differently in our management with diuretics, afterload reduction, pressors, kind of riff on that one a little bit. Like, let's intubate this patient. We're going to convert them from a negative intrathoracic pressure to a positive intrathoracic pressure and totally screw up all these measurements and kind of go with that one, Z. What do we do with that?
Yeah, one of the main things or the first things I would worry about, just because we had so many patients with pulmonary edema who got intubated, is when you're in negative pressure ventilation mode. This is very advantageous. You improve venous return when you breathe in, and when you breathe out, it's a passive process. It doesn't affect hemodynamics. Once you intubate that patient and put them on positive pressure ventilation, you reverse the situation. You reduce preload and you reduce afterload. Reducing afterload is good, but reducing preload in this particular patient would be bad because they have aortic stenosis and their cardiac output is on the lower end, and they have diastolic dysfunction, so their filling is not that great because their relaxation is not that great. So imagine someone who has normal lungs and you intubate them and you put them on a pressure of 10, on a PEEP of 10. Forget inspiration pressure for now, just the PEEP, which is continuous pressure. Some of that pressure is going to translate into the transmural pressure on the heart and limit filling during diastole. If the lungs were normal, almost half of that pressure is going to go into the transmural, is going to have a transmural effect. But if the lung is stiff, most of it is going to go there. Some people would say all of it. It's never zero or all, but let's imagine someone is intubated on a PEEP of 10, and I reduce their filling load by 10. And that might be severely detrimental to the cardiac output, especially with diastolic dysfunction, aortic stenosis. So I'm going to end up intubating someone who has high pressure pulmonary edema. I'm happy I reduced the afterload with the PEEP, but I also reduced preload in someone who's preload dependent. So I'm going to start them on pressors. There is no reason to give someone in this situation something to just beat up the heart for the sake of vasoconstriction. And of course we will, because we're going to use Levophed because it's the most effective and it's the standard of care. Once you do this, you're going to cause probably a little bit of myocardial ischemia. I can imagine this person already has some coronary artery disease. And then I'm going to reduce afterload. I'm going to reduce cardiac output. I'm going to cause renal failure. So I would try in this patient to do a lot of medical management without putting them on high pressure, adding pressure to their lungs, adding positive pressure to their lungs. They are safer if they are breathing with their own negative pressure breathing mechanism. So, of course, this is in theory. If the patient needs to be intubated because they're hypoxic, they're coughing up a little bit of pink, and you don't have time to figure it out, then you're going to intubate them. But then, if they become hypoxic, am I going to increase the oxygen, or am I going to increase the PEEP? Or am I going to try to go with a high PEEP ladder or a low PEEP ladder? It depends on the hemodynamics that I'm dealing with.
Do you think there's a role for an alternate pressor agent like a dobutamine or milrinone?
It's not standard of care, but if this person was admitted to cardiology, I'm sure they would experiment in alternatives, and probably dobutamine would be a good agent, although it might not provide a lot of vasopressor support. Yeah, if there is enough coronary artery disease, it might be the right thing to use. Milrinone, I don't have a lot of experience using it. So, but again, don't try to treat the pulmonary hypertension with a vasodilator in this pulmonary vasodilator in this case, because the hypertension is secondary to the pulmonary hypertension is secondary to severe LV disease.
No, I think that's a great point, because that's one of the thoughts that kind of trickled through my head as I was kind of digesting this case is, do you need to concurrently treat your pulmonary pressures? And I think the answer here you just gave is no. And the other kind of takeaway for me is, when we intubate someone and their pressure drops, we think kind of that first order of events. I just converted them to a positive pressure situation. I dropped their preload, so maybe I need to augment their preload by giving volume. And while that may not be wrong in certain scenarios, in this scenario, maybe giving that extra volume back is probably going to be not helpful, because, we're we're probably, our volume's not our problem, it's our pressure. And so maybe, initial pressure support is going to be, trial pressure support is going to be more effective in that scenario. So I think
and
that's
I found,
go ahead.
yeah, and I found myself using Lasix and fluids at the same time too. I mean, sometimes you're pushed into that situation.
All right, you ready for the big one?
Sure.
The big teaser here. So we talked about all this, the aortic stenosis, they're very preload dependent. We talked about all the preloading conditions at every step down the way, the LV, LA, pulmonary vasculature, RV, RA, IVC. We hit all of that today. This next scenario, patient's RV takes a dump, right? So all of a sudden now our TAPC is no longer 17, it's 10, right? So we have RV failure in a patient that's very dependent upon their preload and it's got some elevated pressures kind of upstream from that, up or downstream, whatever direction you want to say, that goes through the lungs and into the LV. Now what do we do?
Great. And it happens. You intubate the patient, especially folks who have a reason to develop atelectasis or airway obstruction, or maybe the PE that nobody wants to think about, and suddenly RV stops working. And that is gonna put a lot of pressure on the septum. The RV to LV ratio in this person was about 1. And the septum wasn't flattening, but imagine if that septum flattened out. That will make preload, filling, pressure even higher. Now, why did the RV tank? If I have time, I'm probably going to look for a PE and I'm going to look for ischemia. And if I can't find or fix either of those two, I'm going to assume something happened to the lung to increase their pulmonary vascular resistance. And that's the reason. Either they opened a shunt that caused hypoxia, or I caused atelectasis, such as in a heavy patient who is now flat and paralyzed, or I intubated the wrong segment, or they aspirated. Something caused the pulmonary artery pressure to go up. And in this situation, you just have to treat with preload. I'm going to drop the PEEP a little bit, try to increase FiO2 instead. And I'm going to give them volume, although I know I'm going to cause probably more pulmonary edema, because if I don't have forward flow, I'm not going to have a patient. So that would be the priority. But if I have time, I have to definitely look for why the pulmonary artery pressure went up, that caused, or why did the RV fail primarily, maybe because of a right-sided coronary syndrome.
All right. I think we'll call it a wrap there. Thank you. That was very helpful. But yeah, thank you guys for joining us today. I think hopefully this case was helpful as we kind of worked through kind of a case that we saw in the ED and kind of nuanced it a little bit, kind of added some scenarios and kind of played with the different conditions to see kind of how we could use the ultrasound to assess our cardiopulmonary hemodynamics, as well as kind of how we then manage the patient at the bedside and what effects that's going to have.